I most definitely will, yes. So the background of the CFDI was to identify all the patients in Canada that has Fabry's disease. The reason being why this was so important to the patients is that healthcare in Canada varies from province to province. So whether or not they receive treatment for Fabry's disease also varied from province to province. So the CFDI, in order to participate in it, you need to have a confirmed diagnosis of Fabry's disease, be between the ages of 5 and 85, be able to give informed consent, be compliant with quite a rigorous study testing schedule, and of course be a Canadian citizen. So as alluded to, the Canadian Fabry's Disease Initiative, or CFDI, covers all Canada, and that's coast to coast, and that's quite a big area to cover. So the national site is in Halifax with Dr. Mike West. There's a site in Montreal, Quebec, that is ran by Dr. Daniel Boucher. Toronto is still ran by Dr. Joe Clark, even though he is retired. Calgary is where I'm based out of, and the principal investigator there is Dr. Robin Casey. We also cover the prairie provinces, so that includes Manitoba and Saskatchewan, and that's due to the low population is why we have such a big area. And in Vancouver, or on the other coast, is Dr. Sandra Sears. So you can see the stars on the map of Canada is where the 5 principal sites are at. In the little black dots, such as the black dot in Alberta there, is the satellite sites. So there's some of the provinces do have other specialists in metabolic diseases that also are interested with regards to being involved with the CFDI. So as I covered in the beginning, we really did need a national initiative for rare diseases like Fabry's disease, and the inconsistencies among the provinces were just too great, and it just really wasn't fair to the Canadian population as a whole to just because where you live, whether or not you were getting treated. So our goal, of course, is to acknowledge all the patients with Fabry's disease, and then we divided them into 3 different cohorts or 3 different groups for the study. So the first group is called Cohort 1A, and it is patients that were on enzyme replacement therapy when the CFDI began in 2006. The next group was called Cohort 1B, and those are the patients that have met the criteria to be started on enzyme once the CFDI started. And then the last cohort we call 1C, or the natural history cohort, and those are the patients that are followed by the Canadian Fabry's Disease Initiative, but they don't meet the guidelines for treatment for enzyme replacement therapy. So the study design can be nicely gridded out like this, with the very top of it being Canadians with Fabry's disease, and then on the right-hand side are those people who do not meet the treatment guidelines. They're followed in the natural history. But if they do meet the treatment guidelines during the study, they're shifted over to the left-hand side. And then if they were on ERT before the CFDI started, they were 1A. And if they were not on enzyme and started enzyme while the CFDI was already started, they were randomized into the 1B category. So everything was running along quite nicely, but unfortunately we came into a supply shortage. So year 4 of the 7-year initiative, many patients that were on the one enzyme had to be switched over to the other enzyme due to simply not having the supplies that are needed to treat them. And one thing that all the principal investigators across Canada agreed upon is that they would not settle for treating patients on an off-label dose or treating patients at half the recommended dose. And being a study, they do need to stick to certain mandates, and I know that came up in this morning's talk as well. So the guidelines for the CFDI are based upon different organs, so renal or kidney, heart or cardiac, neurological, and that's with regards to having strokes or not having strokes. GI, typically GI pain, or the problem with GI system being so bad that it's affecting your daily activities, and pain being the last one. So the goals of the CFDI are they're published on the website, the CFDI website. But the first goal was to develop a national registry that allowed for all the patients in Canada with Fabry's disease to be part of it. Another goal was to determine the degree of which existing complications related to Fabry's disease respond or not respond to enzyme replacement therapy. Again, it was alluded to this morning that enzyme does not enzyme replacement therapy treatments. Halfway through the start of the Canadian Fabry's Disease Initiative, we realized that we needed another little tool in order to help put together all this information that we had. And so we called it the Composite Clinical Outcome. So we paid special attention to kidney, heart, cerebrovascular, and of course death. If people died, it was a special marking on the paper and on the database. So data adverse events, so to not only enzyme replacement therapy as well as anything that has gotten worse when they started on the CFDI have been monitored. And the study coordinators or data entry clerk are trained to put the data into the database. So we are monitored by the ISOC committee, so the International Scientific Oversight Committee, and they monitor our progress, results, changes, and ethics to that. We are funded, originally we were funded by Health Canada for a period of the first year, but then that quickly changed, so funding is now provided by provincial governments and private industries. We do have an independent sponsorship called the Canadian Fabry's ERT Research Consortium, and as I mentioned, the current contract is up September 30th of this year. So we do have a monitor that comes into every site at least every year, and she makes sure that the information that gets put on the database is true to what happened to the patients. So the completeness of the data that we collect from the CFDI does vary a bit from site to site, and that's because each site was already set up and functioning as a clinic before the CFDI came in. So another variance is whether or not the principal investigator, the PI, orders the tests. So if they order the echocardiogram to get done, ECGs to get done, there's a higher chance of them getting done than if they just act as a consultant and leave that to a cardiologist to order and get done in the frequency that we like to get them done for the CFDI. The focus, of course, so we're quite successful in doing estimated glomerular filtration rates. So that's, of course, based on a blood work from creatinine. And across Canada, we're getting between 88 and 100% data put into our database for that. For protein in the urine, which one would think is a simpler test to collect urine than it is to collect blood, we're a little bit less. We're at 84 to 100% across Canada. So the reason why the glomerular filtration rate is slightly higher is that as part of the CFDI, we're taught with regards to a formula that we have to use to calculate it, but the protein is just done on a urinalysis. So sometimes that urine is missed getting collected, and sometimes it isn't. So echoes sometimes vary and are quite difficult to get done at certain sites. So the percent of getting that collected is between 77 and 93%. ECGs are between 81 and 100%. At our site, we're a children's hospital, but we also see adults there, and so we can't get an adult ECG done on site. So we're in the little bit of the lower range with regards to that, but we still get them done just outside our hospital. Brain MRIs vary a huge amount, between 38 and 76%. Again, the reason being is some sites it takes several years to get a brain MRI booked. The other reason why that number could be low is that we changed the monitoring of the MRI halfway through the CFDI. We were doing brain MRIs every year, and then we changed it to be monitored every second year. So the conclusions for the CFDI is that it's been a great study to work with. It's fascinating to watch the CFDI grow, and the knowledge as well as the PIs keeping up with most current knowledge and changing the protocol as needed. And it's a very dedicated, as well as a small group to work with, and they all know each other and support one another. So it's been just a really good group of people to work with. Besides the PIs, of course, there's associate investigators that are part of the satellite sites, research coordinators like myself, labs. We get the labs done as much as possible at one site, and a special thanks to, of course, our financial sponsors. And without that, CFDI wouldn't be what it is. So I'm open to
Thank you, Colleen. As you said, I think one of the nice things about it is that it was a nationwide study, and it was not sponsored by industry, and it was looking at both products. It's a pity that we had the shortage of Fabrazyme in 2010. Otherwise, I think we would have had, very important information from that study. Jerry.
So, as I understand it, the initiative, every person in Canada that has been diagnosed with Fabry disease is in that 318.
Every person in Canada that has been diagnosed with Fabry's disease has been personally asked by a PI to join the CFDI.
So, and of that number that you have, 318, which may exclude you, I guess.
There's approximately 8 patients that, for whatever reason, chose not to join the CFDI.
But almost everyone in Canada.
Almost. However, when you consider the alternative, if they meet treatment criteria, their enzyme is funded for. If they're not part of the CFDI and need treatment, they need to come up with their own money or join the CFDI.
So of the 318, the way I understand it is everyone is randomized to one of the drugs. So people randomly are chosen to either receive Repligal or Fabrazyme.
Exactly.
And then there's the third group of the people that aren't on treatment. Do you have the numbers of the 3 groups of the 3 teams? What makes up the first cohort, the second cohort, and the third of people who are not receiving treatment?
Yeah, I do have those numbers. I don't have them with me.
Just curious how many people of the 318 are receiving some sort of ERT and how many are not receiving anything yet, and how many of those are
So
children
in fact,
and
it would
adults?
be 2/3, 1/3, isn't it? Because there's so many patients who are on ERT.
So I also understand it is, you mentioned the shortage, that this is really good data because of the initiative, there was no shortage in Canada.
Yes, and I also, Atul and Tariq, I was just looking to see whether Tariq was here, Dr. Hypot. They are really looking at analyzing the data during the period of the shortage. So they've got some very important information on all the adults. And again, they've joined together for the whole country.
Right.
And they will be looking at that data. And I think that's really vitally important. Those who switched, those who stayed, and those who were on lower doses or lower than the licensed dose. So that information will be, I think, vitally important to gather. And then when you compare that with CFDI, maybe there will be even more important information on really can we talk about dose, as we mentioned this morning.
Better data in this study than most.
Looking at the ranges of, if I understood you correctly, Colleen, in terms of participation on the different tests and things that are done, if you're looking at 77 to 93% on echo, 84 to 100% on protein, and then you have the shortage as well. If you don't have a consistent level of participation, then how can you be really confident in the results that you're getting?
I think it's like with every other study, isn't it?
We still follow the patients regardless of the shortage, and we were quite fortunate in Canada when the shortage happened that the patient didn't stop receiving enzyme. They were switched right away over. So they may have delayed infusion by a few weeks, but that would have been the most. It wasn't like they were stopped. We still continue to follow them every 6 months, as always.
So,
Yeah, I'm confused.
excuse me, Joe. So on these ranges, I guess I misunderstood because I thought that was the consistency of obtaining those tests and being able to put that information into the CFDI.
From 2006 to 2011, yes.
And some of
Okay.
those, so for example, our site never did ECGs before the CFDIs. We're
Right.
metabolic physicians, not cardiac specialists. We
Right.
didn't even know the importance of an ECG.
Right, but you do,
right?
but you do
But
them.
we do now.
Right.
So our baseline patients, because everything was started with one
It
big
was
boom,
2006.
yeah, was quite low compared to we're very good.
Oh, okay. So from 2006 to 2011, though, the input of all of these measurements
It
is
has
consistent
increased.
site to
Yes,
site?
yeah.
Okay, good. Thank you.
But so I guess I'm confused, and maybe I'm not hearing everything, but I understood Dr. Serge to say that because the Canadian Fabry Disease Initiative is a clinical trial, and everyone in a clinical trial was exempted from the shortage, then there was no shortage in Canada. That's what I understood.
So there was a shortage in Canada. It was a global shortage. We were affected like every other country was. But what they were able to guarantee for us is to treat X number of patients throughout the shortage. So, and that number was like 13 or 15 compared to like the 50 or 60 that we had.
Okay.
So it wasn't that we weren't affected by the shortage, but what happened during the shortage is no Fabrazyme was available. They were switched right away to the rest of that.
Gotcha.